talk is about the cost effectiveness of vancomycin powder for deep wound infection prophylaxis in spine fusion, particularly lumbar spine fusion. This is my team that collaborated in this paper, and none of us have any conflict of interest to report. Vancomycin powder in the prophylaxis for lumbar spine fusion has slowly gained popularity. It's applied locally, just in a powder form. It is still considered, at least in Mexico, as an off-label use, but the purpose or the goal is to achieve high to very high local concentrations in the surgical site, particularly below the fascia. In our paper, we reviewed the patient's records, capturing those who had a surgery, a lumbar fusion between March of 2016 and April of 2017. So it's a retrospective study. We did 1-year follow-up in coordination with the epidemiology service, who also checks our patients. And so we have a double way to catch our patients, so we don't lose any patients. So we monitored them, at least in the paper, to see if they developed any deep tissue infection of the surgical site. And as a reference, at the time of the paper, 1 gram of vancomycin powder was costing to the institute 85 pesos, which is at the time about 4.5 US. And we compared 2 groups. The first group received the conventional prophylaxis, and the second one received an additional dose of vancomycin. So it was the conventional plus 1 gram of vancomycin previous to the closure. And the other group received 1 gram of cephalotine and 3 additional doses post-op, considering that the first dose was applied 30 minutes prior to the incision or at the time of the incision. We had a total of 184 patients. 102 of them were conventional prophylaxis, and 82 of them were conventional plus the vancomycin powder. In our distribution of the whole 184 patients, 92 patients were conventional prophylaxis with no infection. 80 patients were conventional plus vancomycin with no infection developing. And the smaller groups are the infected group, which is 10 patients that had the conventional prophylaxis, represented 5% of the total 184, and only 2 patients develop an infection in the prophylaxis plus vancomycin. So it turns out that it's 9.8% of infection rate in the conventional prophylaxis and 2.4% in the study group. These are the isolated germs for microorganisms. The 2 main, or the 2 more frequent ones, were E. coli and MRSA. The purpose of having vancomycin is especially to prevent MRSA infection, particularly focusing our attention in the infected patients. The average age was 60 years of age. The main BMI was overweight. So we had an important population of our patients with either obese or overweight. Also, the bleeding was an average 1,000 cc's, which is also a parameter for slightly higher risk of infection. Surgical time of over 300 minutes on average, considering that the maximum level of fusion was 8 levels. And the hospital stay was estimated, or it was the average of 15 days with a maximum of 30 days. And the appearance of symptoms after surgery was averaging 43 days, considering that we did have 1 patient who went over 300 days before the symptoms started. This is the antibiotic costs for the patients that received antibiotic treatment for the infection site. The most expensive treatment was with meropenem, but the overall treatment sum was over $1,300 US for all the patients. So when we did the average cost for patients that did not have any surgical site infection, it was averaging just under 4,000 US. And patients who did develop an infection average 7,700 US. This is excluding the implants. So this is just the hospital costs and antibiotics, the MRI and the studies and the blood tests that were done. This is, unfortunately, all patients were able to preserve their implants. When we did this cost-benefit analysis, considering the cost of the patients with the surgical infection site and the patients without it, when we considered that for every 100 spinal fusions, it averaged just over 75,000 US, and considering the cost of vancomycin powder for a single dose or a single gram per patient, it's only 450 US. So when we do the math, if we consider 10% and 3%, just to do just to make the math a bit easier, if we do 100 fusions with the conventional prophylaxis, considering the previous data, it would cost an estimate of 434,660 US compared to 408,578 US in the conventional prophylaxis plus vancomycin. That will give us an estimated savings of 26,000, just a bit over 26,000 US per 100 patients fused and treated with vancomycin, additional to the conventional prophylaxis. During the development of this and a previous study in the same center, some of the surgeons were a bit concerned if there was a higher risk of a seroma or a higher risk of pseudoarthrosis. And in this revision, in the Spine Journal of 2015, there was a slightly higher incidence of a seroma, although it turned out not to be statistically significant. And considering the risk of a possible pseudoarthrosis, there is this paper from 2010 where we see that locally, if this antibiotics are applied, there is a change in the osteogenic cell viability and activity, being tobramycin, vancomycin, and amikacin, the ones that had the least decrement in osteogenic cell viability, and others such as gentamicin, which is also popular applied locally. Amongst these others, as rifampicin, also considered as a biofilm cracker. This antibiotics had a negative effect on our osteogenic cell viability. And shown in this graph, we see that of this antibiotics, vancomycin has the least impact both in cell number and also in the activity of alkaline phosphatase, considered in this sense more safer antibiotic considering a fusion. Now, if not in low risk patients, there are some risks that we need to consider again that will add up to increase substantially our relative risk for a surgical site infection, such as patients over 65, a BMI either below 18 or above 35. It can increase almost 3 times as much with highly obese patients. Also diabetes, patients with chronic heart failure or chronic obstructive pulmonary disease or peripheral vascular disease, all of these individually increase quite significantly our relative risk for a surgical site. And at least in our population, there are several patients that have diabetes and congestive heart failure, so we have to add up all these factors that on their own are quite significant. Other surgical factors on this paper, they did not specificate why male had this almost a bit over twice as much odds ratio for surgical site infection, but also again, diabetes has an important factor, a malignancy history or anesthetic risk of over 2. So most patients with either above 65 or any previous condition would be twice as much. and also the days that we have the drain installed. So the longer we keep that drain in per day, it's 1.6 odds ratio of increments. And it's not only in instrumentation where it's shown to be cost effective. Also in this paper recently published in the Global Spine Journal, in this break-even analysis, they performed to determine the absolute risk reduction in an infection rate to make the prophylactic application of vancomycin powder to be cost effective. Costing in this paper $3 per gram, vancomycin powder was determined to be cost effective in lumbar laminectomy. And if the infection rate of 4.2 decreased by an absolute risk reduction of just 0.015%, laminectomy with a fusion was also determined to be cost effective. At the same time, vancomycin powder, if the infection rate of 8.5 decreased just by an absolute risk reduction of 0.00334%, was also considered cost effective. So they conclude that in that break-even analysis, they showed that it was highly cost effective for laminectomy. And also in arthroplasty, shoulder and hips, it's been also studied. And in this particular paper, also fairly recent in 2016, this cost data from infection-related care of 16 patients treated for deep prosthetic shoulder infection also showed to be highly cost effective, using the current cost in the literature between 2.5 US and $44 per gram. They determined that the absolute risk reduction rate of just 0.01% at the cost of 2.5 per gram, and if it's 0.19% at the cost of 44 US per gram. So at the end, they consider to also be highly cost effective in their practice. Although in this other paper from 2019, it turns out that in this paper, they considered to be cost effective, although they didn't find any statistical difference between both groups. So summing up, the use prophylactically as a coadjuvant for prophylaxis, it's viable and is cost effective option both for fusion, laminoplasty or laminectomy alone, or even considered in joint replacements. It gives us this local super therapeutic and safe levels. Considered that in other papers, it shows that it has very low systemic levels since vancomycin is hardly absorbed through the tissues. There's still evidence to show which dosing regimen is the ideal. In papers in spine, it's averaging it to be 1 gram, although in patients undergoing deformity surgeries or very long fusions, they're using up to 2 grams. Unfortunately, most of these papers are low-level evidence. There are some meta-analysis, and the conclusion is the same, that the actual evidence of most of these papers are mainly low evidence. Also, a factor that we considered, although not reported, we didn't find as a factor considered in literature, is how we do the skin closure. If we do an intracutaneous suture, we consider it to be a better approach since we can get a tighter closure compared to standard single sutures or staples. And at least we consider that if not in all patients, at least we would consider it highly advisable in high-risk patients as a prophylactic approach, particularly since they have a higher risk and the cost of these patients tends to be higher for their treatment in surgical science infections. Thank you very much. These are some of the references used for this talk.